Good afternoon, everyone. My name is Nabeel, Sheikh. I'm one of the cardiology registrars and research fellows at St George's Hospital and University of London. And as ever, I'd like to start by thanking CRI for inviting me here to give this talk today, which is called Athletes with HCM, Black and White or 50 Shades of Grey. So before I begin, I'd just like to set out a few aims and objectives. The first of which is really to remind everybody about how athlete's heart can overlap with hypertrophic cardiomyopathy and the importance of distinguishing between the two. I'll then go on to talk to you about how we currently differentiate athlete's heart from HCM and how some athletes with HCM may not actually fit into this traditional model that we have about the disease. And finally, I'll present some new data that we've been gathering at St George's about the phenotypes specifically in athletes with hypertrophic cardiomyopathy, and the importance of this will become clear as the talk goes on. So we all know that sudden death in a young athlete is a rare but tragic event, and it's usually caused by a number of congenital and inherited cardiac conditions, such as the cardiomyopathies, which account for up to 50% of cases. Indeed, hypertrophic cardiomyopathy itself is the leading cause of sudden death in young athletes worldwide, accounting for over a third of cases. And apart from the characteristic asymmetric left ventricular hypertrophy, one of the other features of the condition is that most individuals exhibit an abnormal ECG, and one of the most commonest abnormalities are T-wave inversions. And it's perhaps because of this that although most people throughout the world agree that all young competitive athletes should have some form of screening with history and examination, in Europe we advocate the routine addition of a 12-lead ECG. And further investigations are then warranted if these are abnormal, including echocardiography. So, in theory, this all sounds very straightforward, until we remember that cardiac adaptation to exercise, otherwise known as the athlete's heart, is itself associated with a number of electrical changes, including repolarization anomalies such as T-wave inversions, and a number of structural changes on echocardiography, including increased wall thicknesses. And although in the vast majority of cases these changes fall well within the boundaries of normal physiology, in a small but significant proportion of athletes they may overlap with those seen in pathological conditions such as HCM. I'll give you an example. This is an ECG from a young athlete, and you can see the T-wave inversion in the anterior leads. If we look at his echocardiogram, we see that he exhibits left ventricular hypertrophy in a concentric pattern of the order of 12 to 13 millimeters. And therefore, a common dilemma that we face in day-to-day practice when we see an individual with repolarization changes on the ECG and a gray zone wall thickness of between 12 and 15 millimeters is whether this represents morphologically mild hypertrophic cardiomyopathy on the one hand or physiological athlete's heart on the other. And from what you've heard today and what I've said so far, it's obvious that distinguishing between the two is very important. Now, how many athletes fall within the grey zone depends completely on their demographics. For example, for adult male white athletes, this grey zone equates to approximately 0.4% of individuals. However, we have to remember that other athletes exhibit more changes. For example, in the case of Afro-Caribbean or black athletes, the grey zone is tenfold greater because they exhibit an eightfold greater prevalence of T-wave inversion and a sixfold greater prevalence of left ventricular hypertrophy. So moving on, how do we currently differentiate athlete's heart from HCM? Well, there have been a number of algorithms described in the literature, but the most famous is probably that proposed by Barry Maron's group in the 1990s. Now, this algorithm has a number of facets. You've probably seen this before earlier today, but I'm going to concentrate on the ECG, but particularly the echocardiographic parameters contained within this algorithm. Now, because hypertrophic cardiomyopathy is characterized by bizarre ECG patterns, it can have increased left ventricular filling patterns which cause LA dilatation. It's characterized by unusual patterns of LVH and abnormal diastolic filling due to a stiff ventricle. According to this algorithm, the presence of any of these suggests hypertrophic cardiomyopathy, whereas the absence point more towards athlete's heart. In addition, because the hypertrophy in HCM usually occurs at the expense of the LV cavity, the LV cavity is usually small in hypertrophic cardiomyopathy, but because athletic training is invariably associated with some degree of LV cavity dilatation due to volume load, according to this algorithm, a cutoff of greater than 55 millimeters strongly suggests athlete's heart. However, we have to question this algorithm when it comes to athletes with hypertrophic cardiomyopathy, because the data from such algorithms have been derived predominantly from sedentary individuals, particularly these parameters that we use in day-to-day practice, including LV filling and LV cavity dimensions. These are the commonest parameters that we use in day-to-day practice to help us distinguish HCM from athlete's heart. But they have been derived from sedentary patients. And we have to ask ourselves, in athletes with hypertrophic cardiomyopathy, is it always this black and white? Well, in some cases it is. This is an example of an ECG from an athlete who was screened, and you can clearly see widespread T-wave inversion with resting ST segment depression. And if we take a look at his echocardiogram, there's a small left ventricular cavity of less than 45, asymmetric septal hypertrophy of greater than 15 millimeters, and impaired diastolic function. Remember, an E to E prime of greater than 12 is abnormal. And I think in most people's mind, there can be no doubt that this represents hypertrophic cardiomyopathy. However, in our day-to-day practice with athletes, we see that there are a number of shades of grey, and I'll give you some examples. So this was a Premiership football player screened and sent to us. And note again, he has widespread T-wave inversions in the infralateral leads. However, this time, if we look at his echocardiogram, instead of a small LV cavity size, we actually see LV cavity dilatation of 63 millimeters. And in addition, he only has mild concentric left ventricular hypertrophy. Furthermore, when we look at his indices of diastolic function, these are completely within normal limits. Now, because this athlete was a top player and he had repolarization changes, we went on to perform a cardiac MRI scan. And this demonstrated apical left ventricular hypertrophy. In addition, the player was coming towards the end of his career and he didn't mind having genetic testing. And we gene tested him and found him to have a pathogenic genetic mutation for HCM. So he was diagnosed with apical hypertrophic cardiomyopathy. But if we go back to our algorithm, we can already see that in the case of this individual, this starts to fall apart a little bit. This guy had a normal LV filling and a dilated LV cavity. But we don't know whether this was just a one-off anomaly or whether all athletes are like this. I'll give you another example of the shades of grey that we can come across. This is now an ECG from an Afro-Caribbean athlete. And again, you can see widespread T-wave inversion. Once again, when we look at his echocardiogram, we see that there is mild concentric left ventricular hypertrophy up to 14 millimeters. And remember, Afro-Caribbean athletes may exhibit LVH up to 14 or 15 millimeters in response to just exercise. And again, there's LV cavity dilatation with normal diastolic function. Now, this individual's cardiac MRI scan was completely normal, and he didn't want to undergo genetic testing. But we screened his family as part of these findings, and his father was actually diagnosed with hypertrophic cardiomyopathy. So at this point, we thought that perhaps this individual has early disease or incomplete penetrance of the condition. However, he came back to our clinic after having injured his ankle 8 weeks later, and to our surprise, his T-wave inversions had completely resolved, and this can be better appreciated if I show you the two ECGs side by side. So again, we had to question in our mind, does this athlete really have hypertrophic cardiomyopathy? So it can be seen that when it comes to athletes with hypertrophic cardiomyopathy, there remain a number of unanswered questions. For a start, we don't really know at the present what the phenotype of athletes with HCM is. All of the data out there on HCM is derived predominantly from normal or sedentary individuals. In particular, we don't know in terms of their electrical phenotype whether they have more or less ECG changes, and in terms of the structural phenotype, whether they develop more or less LVH, whether certain patterns of LVH are more compatible with exercise, such as the apical variant. We don't know whether their LV physiology is normal, like the two cases I showed you, or those were just anomalies. And we don't know whether exercise itself can modulate the HCM phenotype, for example, by causing LV dilatation, as it does in normal, healthy athletes. In addition, as the last case illustrated, we don't know whether exercise might bring out a concealed HCM phenotype. And finally, we don't know what the implications of all of this are for pre-participation screening. So it's with the backdrop of these questions in mind, and particularly number one, that we started gathering data at St George's Hospital in collaboration with Prof. Carrier's group in France on athletes with hypertrophic cardiomyopathy. So over a 14 to 15 year period, we went back through our data and identified 103 consecutive athletes with hypertrophic cardiomyopathy who had presented to us, or Prof. Carrier's group, who had been screened with a 12-lead ECG and echocardiogram. And in order to determine the effect of exercise on the HCM phenotype, we compared the data from these individuals to data from 106 age and ethnicity matched sedentary HCM patients. Now, just to talk about the athlete group, these were individuals who were all young, asymptomatic, and identified predominantly through either pre-participation or familial screening. In other words, they were individuals we would expect to encounter in our day-to-day screening practice. And in addition, we looked at the initial presenting ECG and echocardiogram. In other words, not data that was later on in the disease when the disease was well established. So the initial presenting ECG and echo. And these are our results. So I'll start with the ECG changes because these are the hallmark of HCM. And we'll start with T-wave inversions because these are characteristic of the disease. And unsurprisingly, over 3/4 of our cohort of sedentary HCM patients exhibited T-wave inversions, which were predominantly deep and in the lateral leads. However, compared to our sedentary patients, our athletes with hypertrophic cardiomyopathy exhibited significantly more T-wave inversions, both overall and deep, and in the lateral leads. The prevalence of T-wave inversions in other areas, in the anterior and inferior leads, were no different between the two groups. And you can see from this graph that nearly all athletes had T-wave inversions, athletes with HCM, that is. Going on to other ECG changes, there were no significant differences between the two groups, apart from with voltage criteria for LVH, ST elevation, and ST depression, which were again significantly more prevalent in the athletes with HCM compared to the sedentary HCM groups. So already we're building up a picture that athletes with HCM appear to have a worse looking ECG than sedentary ordinary HCM patients. In terms of other important ECG findings, we observed that no athlete with HCM exhibited right or left atrial enlargement, right or left axis deviation, or right ventricular hypertrophy in isolation on the ECG. In other words, they were always found in combination or with other ECG changes such as T-wave inversion. And importantly, less than 2% of athletes with HCM exhibited a normal ECG, compared to nearly 7% of the sedentary patients. So moving on to the echocardiographic features, and in stark contrast to the ECG phenotype, we found that compared to sedentary HCM patients, athletes with HCM actually exhibited a milder echocardiographic phenotype with significantly less left ventricular hypertrophy. And in terms of their LV cavity dimensions, we actually found that athletes with HCM did develop some LV cavity dilatation. Indeed, if we take our cutoff of 55 millimeters as proposed by our algorithm, we actually see that 10% of our athletes with HCM exceeded this cutoff value. Now, unsurprisingly, the relative wall thickness was larger in sedentary HCM patients compared to the athletes with HCM because they had more LVH and smaller cavities, and it's just the ratio of the two. But importantly and interestingly, nearly all athletes with hypertrophic cardiomyopathy had normal parameters of diastolic function. I'm just showing you the average E to E primes here, which should be less than 12. So this was a very important finding. But it can already be seen that, according to our data, athletes with HCM don't really fit into these traditional models. Not every athlete with HCM may fit into these traditional models of the condition and differentiating between the two. And finally, systolic anterior motion of the mitral valve leaflet was relatively rare in our athletes with HCM compared to sedentary HCM patients. And finally, we also looked at the pattern of left ventricular hypertrophy, and compared to sedentary HCM patients, we found that athletes with HCM exhibited a significantly greater prevalence of the apical variant of the disease, whereas other patterns were no different between the two groups. So in summary, the data that I've just presented does appear to show that exercise can modulate the phenotype in HCM. In terms of ECG changes, Athletes with HCM appear to exhibit more T-wave inversion, which are particularly found in the deep and found in the lateral leads, more ST elevation, LVH, and ST depression, and isolated ECG patterns or normal ECGs appear to be rare. And we don't really know the mechanism of this, but it may be due to induction of gene expression with exercise that affects your repolarization on the ECG. In terms of structural differences, athletes with HCM tend to have less LVH, more of the apical variant, and they may actually have large cavity dimensions in contrary to what we normally think. And most appear to have normal indices of diastolic function. And this may simply be because athletes with severe LVH or diastolic function are simply selected out and can't compete at higher levels, so never become athletes. So what are the implications of these findings for screening? Well, first of all, it means that softer abnormalities on the ECG are unlikely to represent HCM when observed in isolation on an athlete's ECG. These include our left and right atrial enlargement, axis deviation, and RVH. And it also means that because the apical variant appears to be more commonly found in athletes, this should be looked for and comprehensively excluded when T-wave inversions are seen in an athlete, particularly in the lateral leads. And finally, the presence of LV cavity dilatation or normal diastolic function should not be used on their own to say an athlete doesn't have hypertrophic cardiomyopathy. So in conclusion, ladies and gentlemen, I'll leave you with two key take-home messages from the data that I've presented. Firstly, that athletes with HCM appear to exhibit a worse ECG phenotype, which is perhaps contrary to what we might have thought, but it does mean that we're unlikely to miss the condition by excluding minor ECG changes alone. And secondly, when it comes to structural changes, athletes do exhibit a 50 shades of grey, with many different patterns recognized. They may have less LVH, a greater prevalence of the apical variant, more cavity dilatation, and most appear, from our data at least, to have normal diastolic function. I'd like to thank you for your attention, and I'll stop there, but I'll go back and leave you with that summary slide.